Okay, thank you. Thank you, Mr. Chairman.
Gentlelady yields back. Now recognize the chairman of the full committee, Mr. Guthrie, for his 5 minutes of questioning.
Thank you, Mr. Chair, and thank all of you being here today, and Dr. Corrigan-Curray. First, before I get started on my question, I see Brian Fahey sitting behind you, and I saw him walking around here, and I was thinking it was normal. Then he goes and sits behind you. So you realize you got one of the top healthcare staffers from Capitol Hill to join you. So I really appreciate Brian's service in my office and on our committee, and now in his role in the executive branch. So I appreciate you having he's a great, you'll enjoy working with him. He's two beautiful girls too, so they're saw him start his young family in my office. So first I want to start with, I appreciate what FDA's done on the work to implement a MUFA over the last 5 years. My question, what do you think has been successful with the MUFA, and then what do you like to see different?
Sorry. Under a MUFA 1, it was really let's build this program and starting from scratch and getting, our electronic system, getting those foundational guidances, getting the staff who could do the work. And then, by year, we started to get meetings with companies to start innovation, and we received our first new OMAR for a sunscreen. I think a MUFA 2 really reflects the learnings from a MUFA 1. So one is that we need to provide more opportunities for innovation. And we're going to do that by certain meetings need to go longer if it's a complex question. We're going to offer opportunities to look at protocol synopsis. We understand there's still questions about the GRAS standard, and so we're going to elicit what those questions are and do some more education. We're going to provide more clarity on when you're doing a proposed order for a new active ingredient, including some clarity on the confidentiality of the data that comes along with that and how we treat that. We also understand there's room to grow in the quality area of a MUFA. And so one of the things that we're going to do is we're going to staff up and get those assessments of new facilities. So a facility comes online and starts selling their drug, and we start asking them questions and understand their facility. And we're also going to release those, what we call information requests. They're the questions we ask, because that gives industry more insight into what we are expecting. And of course, we'll any warning letters that might come out, we will. And we're going to update our risk model. So when we're deciding where to go for an inspection, it's specific to the kind of risk factors we might see in an OTC facility. Finally, a lot of transparency we have. So we got our indexing up of our older documents. We want to further give those documents. We're going to have transparency not only around those who don't pay their fees, but those who do pay their fees. We're going to give transparency around exclusivity. And, we're generally going to continue to work with those companies on innovative. We have some proposed orders, as I said, the one about changing the dosage forms. So we're really hoping to move forward on that. So those are some of the examples. Thank you.
Thank you. Thank you for your answer. Mr. Morris says, I mentioned my opening statement about rural health. Can you elaborate on the metrics HRSA uses to measure and improve health outcomes through the Rural Healthcare Services and Outreach Program?
I'm sorry, sir. Can you repeat the question?
Can you elaborate on the metrics HRSA uses on the healthcare program to measure and improve health outcomes on rural healthcare services?
And sort of how we measure
program.
we measure the impact of our
How do you measure the impact of that program?
Yeah. Yes, sir. We looked at for the Rural Healthcare Outreach Program. We look at three main areas. We track, do they improve health outcomes? That's one area. We also look at whether they're able to continue the grant continue the project after federal funding, because these grants are essentially startup funding. They're not ongoing grants in perpetuity. So the idea is we're funding an idea in a community, and the hope is that they can keep it sustainable. And we find that about over 90% of the grantees continue the project after federal funding. And we do find that, like in our most recent cohort, more than 90% of the grantees were able to show improved health status for the people they served. The third area we look at is economic impact, because these dollars have a secondary role in these communities. So for every dollar invested in our most recent cohort, it generated another $2 in economic activity.
Okay, thank you. And Dr. Chin, we're estimated to be over 170,000 physicians short in the next decade. Title VII and Title VIII were created to help increase participation in healthcare workforce. How can these programs be improved? I have about 30 seconds, or streamlined to better meet the need, Title VII and VIII, to help attract more physicians?
I think the most important thing is that they are reauthorized. These programs have been very impactful. We find that our health professions training programs rely on them to support training that is, again, focused on areas of need, whether it's specialties and professions that are in need, as well as integrating content into curriculum and training, for example, behavioral health into primary care, as well as training for rural and underserved communities. So we do find that these programs are very effective.
Okay, thank you. My time has expired, and I'll yield back.
Gentlemen,